Okay. Okay. Hello, everyone, and welcome to our talk on use of adjuvants for pain management. My name is Ayla Pellig, and I am an inpatient geriatrician and palliative care doctor at Mount Sinai Hospital, and I'm here with my colleague, David.
Hey, I'm David Collette. I'm an inpatient palliative care nurse practitioner.
And we're excited to be with you to talk about adjuvants, so I'm going to pass it on to David.
So neither of us have any financial disclosures, and then you can see the keywords here for our talk, and then we'll move on to our agenda. So in this session, we're going to talk about the different types of pain that we'll typically see in palliative care patients. We'll do a brief review of pain pathophysiology. We'll talk about some current approaches to pain management, but we're going to be focusing mostly on adjuvants. And then we'll talk briefly about some non-pharmacologic pain treatment options that we can kind of keep in our back pockets as part of a multimodal approach. So first, let's talk about what an adjuvant is. And adjuvant drugs can be used to enhance the effects of pain medications, treat concurrent symptoms, and provide analgesia for other types of pain. So we think of it kind of just as a co-analgesic. For this talk specifically, we're going to talk about some of the major categories, but we're not going to go into depth in all the different medications that are available. And we're also going to be focusing specifically for geriatric and palliative patients. So for an adjuvant medication, you would want to use it for neuropathic pain, and you would also want to use it before starting an opioid. You might use it when you're escalating opioid doses, or you need to taper a dose, or an opioid is not helping. Essentially, when you kind of want to have a co-pilot or something else that's on board. A lot of different things can be challenging about using adjuvants. It can be difficult to decide which medication that you want to use because there's a lot of different ones to use, even within each specific class. There might be medications that we're not experienced with, or they might be new to us, or there might be different perspectives on things like titration schedules. So, like for example, gabapentin is one that we think a lot that there's a lot of different approaches. There also might be things like side effects or variability in efficacy, or even things like logistical things like insurance coverage. Um, when we think about adjuvant therapy, most of the medications and most of the data are for chronic neuropathic pain and for cancer pain, not necessarily for seriously ill patients or other diagnoses. That's not to say that you can't use these in other patients, but just most of the data exists for that population. We'll do a brief review of pain pathophysiology. So the two major categories of pain are nociceptive pain, which is actual, physical, damage to neural tissue and activates those pain nociceptors. When you see a patient with nociceptive pain, a lot of times, but not always, they'll describe it as like, this is really sharp here, or it's crampy, or it's like a visceral type of pain. Sometimes it can be really well localized, where the tumor is or where the fracture is. And this is in contrast to neuropathic pain, which is actual damage to the nerves. And you might see things like, patients describing it as numbness or tingling, burning, shooting pain. And this is because of abnormal behavior of the nerves. A nice little way to think about it is that, if you're thinking of nociceptive pain, it's an alarm that's triggering in response to a smoke detector, right? There's smoke in the building. Neuropathic pain is more like there's an issue with the alarm system that is going off, whether or not there's a fire there. A lot of the patients that we see are oncology patients, and so it's really important to identify the etiology of the pain. We know that for patients with cancer, a lot of the pain can be tumor-related, neuropathic pain. It can also be treatment-related. We see a lot of chemotherapy-induced neuropathies. But it also might be from things like, they recently had a surgery or a kyphoplasty or, mastectomy, a lot of different invasive things. But we also see it not just from chemotherapy or surgery, but also from radiation. And specifically for radiation, that's something that can manifest, not immediately after, but even months to years after the treatments. And there's also neuropathy that, we see in patient populations across the lifespan, including things like patients with diabetes or other diseases. So when we approach, what we're going to do for the actual treatments, there's three things that we want to kind of keep in mind. We want to choose the medication that's going to be the most effective for the patient. If a patient's complaining of neuropathic pain, we wouldn't want to necessarily start an opioid. We want to treat something that is going to actually treat the right type of pain that the patient was reporting. We also want to make sure that patient safety obviously is an incredibly high priority, and we want to avoid side effects for inappropriate medications. A lot of the medications can cause things like sedation or confusion, and especially with the patients that we're working with, and in geriatric populations, we want to be really careful with that. And then more on a systems level, we want to think about, what type of stewardship we have, right? Are we trying to minimize opioid use when we can? Are we avoiding medication waste? Are we thinking about, conserving medications if there's national shortages? Just using the right medication for the right patient at the right time. And what you can do is you can pause the slide if you like, but just think for a few seconds from your experience. What are some common clinical scenarios where you've seen adjuvants being used from any point in your training? So you can pause and think about that, but I'll just continue on. For me, I've seen patients with chemotherapy-induced peripheral neuropathy quite a bit that we use adjuvants for. We've also seen patients, with neuropathic pain in the setting of malignant lesion, diabetic neuropathies, are all things that we see pretty commonly. It might be different for you based on where you work or practice. All right, so let's talk about the actual neuropathic pain assessment. So, for folks that work in our field, whether it's geriatrics or palliative or a combination, we're really specialists in pain management. And so it's really important that our clinical assessments is in-depth and high quality, especially if this is the first interaction with our team, right? We want to make sure that we're sitting down with the patient and using all the communication strategies that we know about to really get a good history and do a great physical exam. Also keeping in mind that primary teams are really pressed for time and maybe have not had the time to do an assessment in this depth. I'll just mention that there are neuropathic pain questionnaires out there. These are some that you can explore on your own. I'll show you an example of the DN4 next. And in addition to questionnaires and physical exam, there are, obviously diagnostic tests that you can use. Obviously in the hospital, we're using CT and MRI pretty frequently, but also there are things out there like nerve conduction studies that you can also use. So this is the DN4. It's a pretty high sensitivity, high specificity, and it's easy to use. I like this one more than some of the other ones that are out there. If it's greater than or equal to 4, it's likely neuropathic pain. You can see here, or even pause if you want to read it more. But it talks about the characteristics of pain, if it's associated with other types of neuropathic symptoms, like numbness or itching, and if there's other components, is it painful, and if it's 4 or more, then it would be neuropathic pain. So when we think about management strategies, it's super important that we talk about managing expectations. We do this really frequently with nociceptive pain, especially when we're using opioids, is telling patients that we might not be able to get rid of all the pain, but the goal is that we want to make sure that they're in a place where they can tolerate the pain and it doesn't limit their function, right? Also with neuropathic agents or with adjuvants, it takes a little bit longer to either taper these medications or for the onset. It's going to be a lot different than giving someone immediate release morphine, right? And it's also super important that we also tell patients about different side effects that these medications could have, and how they might interact with other medications that they're taking. Okay, so one thing that you've probably all seen before is the World Health Organization's pain management ladder. You might be familiar with the one on the left. That's the one that we've kind of always thought about, is that we start with step 1, with things like non-opioids, adjuvants, take two aspirin or take the Tylenol, and then escalating from there, right? So if it's mild to moderate pain, we'll start adding in opioids, plus or minus an adjuvants, and then, we're going to escalate from there based on pain intensity. There's kind of been a rethinking of that. where we would still escalate as needed, but you can see the arrows going up and going down. And so that's to kind of remind us that, as pain changes and is getting worse, we would escalate. But, if pain is stable or if the underlying thing is getting better, right? So if we're able to resect the tumor or if the tumor is responsive to chemotherapy, we would want to make sure that we come down for that as well, especially when we're thinking about things like opioids, but also neuropathic agents as well. You can also see the step 4 there is if there's no pain relief to, consult our colleagues in other departments or other specialties that could potentially offer invasive treatments, things like nerve blocks, IT pumps, or other things that might be able to help kind of relieve some of those symptoms. So when we think about what some of the first line non-opioid agents would be, there's a lot of different categories that we can choose from. And this is where it can kind of become difficult, like we were sharing earlier. It's like, where do I even begin? So we'd say that, where we would begin is the patient assessment and exam, and reviewing any type of imaging. And then you could consider some of these different agent categories. You have everything from NSAIDs to steroids to SNRIs, antidepressants, and topical agents. We're going to go through each of these categories to kind of give you just like a 30,000-foot overview about when you might want to use those for a palliative care or geriatric patients. What are some things that you might want to monitor for, and some things that you might want to keep in mind when you're using it for a patient who's seriously ill or in a geriatric population. So we'll start with NSAIDs. So we know that, just as a reminder, the NSAIDs, the mechanism of action is that it inhibits the COX enzymes, which reduces prostaglandins, and this results in being anti-inflammatory, helping with pain, and also with fever, antipyretic effects. This is something, you're sore after a workout, you might take this for the anti-inflammatory effects. The most popular example is ibuprofen, but there's a lot of different NSAIDs that are out there, including naproxen, diclofenac, Celebrex, meloxicam, that are both COX-2 selective. For our geriatric and palliative care patients, these are things that we can use for mild pain alongside opioids. For our oncology patients, we always want to make sure that we're using these in conjunction with the oncology team's treatment recommendations, and thinking too that if someone has GI issues, NSAIDs can put you at higher risk for ulcers, GI bleeds. There's increased risk of thrombotic events, renal issues with AKI, and increased risk of bleeding. But overall, these are typically well tolerated. There's no side effects like sedation, and are things that can be really helpful even for a short course. The next category is also super familiar. We all know about acetaminophen or Tylenol. And the mechanism of action is similar, is that it inhibits the COX enzymes, but it does this in the central nervous system. Which helps with pain relief and fever, but it's not going to help with anti-inflammatory like the NSAIDs. So common examples are Tylenol, PO, right? We all know that, and then Ofirmev, which is the IV acetaminophen form. For geriatric palliative care patients, this is something that we would also use kind of similar to NSAIDs for mild pain or alongside opioids, as a nice co-pilot there. Just as a reminder, when we think of Percocet is just oxycodone and Tylenol together in one pill. And so when you're using these with opioids, you're kind of making your own Percocet, but you have the benefit of being able to titrate the opioids. Things that you want to think about clinically is that we talked about the synergistic effect, like with Percocet. The downside is that there is hepatotoxicity risk, and so patients who have any type of liver impairment, whether that's from cirrhosis or from underlying oncology conditions, you want to make sure that you're either limiting the dose or spacing it out a little bit more. A big thing that we see with our geriatric folks, and actually everyone, is that a lot of different forms of over-the-counter medications have acetaminophen in it, and so it's super important that you counsel your patients and their caregivers to Look at the bottle of Dayquil, look at those different, cold and flu medications that they're getting, because there can actually be quite a bit of acetaminophen in it. On a systems level, and for our pharmacist colleagues that always remind me of this, is that the IV formulation is really expensive. I want to say it's in several $100s for a dose, and so that's something that you typically only want to use for medication conservation if a patient cannot take PO for some reason. Another medication that we is a great adjuvant is using steroids. For steroids, they actually activate the glucocorticoid receptors, and so there's really strong anti-inflammatory component to this. And they can have some really powerful effects. In some patients where they've been on pretty high doses of opioids, we've actually used steroids in addition, and they've gotten some really significant relief. Common examples that we are all aware of is prednisone, dexamethasone, methylprednisolone. Specifically for our patient populations, though, things like bony mets or liver capsule pain, a course of steroids can always be super helpful. You want to think about some of the different metabolic impacts that this can have. There is a higher risk of infection, hypertension, peptic ulcer disease. And so you want to consider if you want to, have them on a PPI, if it's going to be something that's longer term. For our GERI folks and for other patients as well, you want to also consider, when you're dosing this, you don't want to give them a dose of steroids right before bed, because then you're going to have them up all night. There's a lot of different approaches to kind of how long that course would be, but typically what we'll do is we'll talk with the patient's primary team, and then use the shortest course possible. Another category that we will often use is muscle relaxants. These depress the central nervous system and decrease the excitability of the neurons. Cyclobenzaprine is a big one that we've heard of, baclofen, nazidine. These can be super helpful if it's actually, muscle spasm pain. The biggest thing that we see is sedation with these, especially when they're used with opioids or any other medication that can cause, sleepiness or confusion. So you also want to be really careful with using this in our geriatric population. Depending on the agent, you might need to, adjust the dose if they have hepatic or renal impairments. And then, obviously counseling for patients, not just with opioids or benzos, but, things that they might be using at home, like alcohol or cannabis.
Okay, so now we're going to be talking about anti-epileptics, specifically gabapentinoids, and I just want to share that since 2011, there's been a huge increase in the use of gabapentinoids, and I think this has been around the time that we've seen more restrictions with opioids, so it's something to be aware before we even get into talking about the medications, just to be aware that the use, and you can see with the different lines, has drastically increased in the number of patients using gabapentinoid medications, and you can see the increase is even more drastic for our older adults as they get into their 70s and 80s. So patients are using gabapentinoids, and it's something to be aware of for all of our patients. The other thing with gabapentinoids to be aware of is that a lot of times people are using them off-label use for pain management or for other medications, and they can be of concern when they're combined with other medications, such as what we call Z drugs, which are a lot of our sleeping aids like Zolpidem, Zolpidem, or Escitalopram or Lunesta. So those are all sleeping aids that when combined can cause a lot more significant harm, and same with opioids. So unfortunately you see an increase in trend, especially kind of starting in 2012 to 2014 or so, with patients that are on gabapentinoids with either a sleeping aid and or an opioid, that their death from these medications is drastically increased. So again, with anything, it's important to figure out what is the polypharmacy effects, but also just to know the cumulative effects of some of these sedating medications together. So these slides are just to kind of make you aware of how the landscape has shifted, especially as more and more providers are thinking about alternatives to opioids, and as we've seen more restrictions in being able to access opioids safely in local pharmacies or just drug shortages in general. So when we talk about anti-epileptics or gabapentinoids, we're talking about the mechanism of action about inhibiting excitatory neurotransmission along the voltage-gated calcium channels in the CNS. So the first medication we'll talk about is gabapentin, a Neurontin. There's a huge range in kind of maximum medication you can give, from 900 to 3,600 milligrams. The bioavailability is quite variable, 40 to 66%. You can titrate up to 3 to 6 every 3 to 6 days. Some people like gabapentin because you can start low and go slow, and some people find it frustrating with how long it takes to taper up. The adequate duration of trial is about 4 to 8 weeks and could be longer on the line of greater than 2 months for chronic pain. So sometimes we have patients that give up on gabapentin because the dose is too little, or they haven't waited long enough to get pain relief, and a few days is not sufficient. And this is also not a medication that can be used as needed. It needs to be taken regularly. The FDA approval is for post-herpetic neuralgia and seizures, but there's a lot of off-label use for gabapentin, including fibromyalgia, anxiety, hiccups, pruritus, restless leg syndrome. It's a fairly affordable medication. Note, especially in our geriatric patients, it can cause dry mouth, sedation, dizziness, edema. So there are significant side effects that can happen with gabapentin. The other major anti-epileptic we wanted to emphasize today is pregabalin, or Lyrica. It has a better bioavailability of 90%. You can titrate it weekly. The FDA approval is for diabetic neuropathy, post-herpetic neuralgia, fibromyalgia, spinal cord injury with neuropathic pain. It can also be used off-label for chronic refractory cough, anxiety, chronic pruritus, restless leg syndrome, so similar to gabapentin, and neuropathic pain. It is more expensive compared to gabapentin and has a similar side effect profile. The next category of medications we'll talk about is SNRIs. It inhibits the serotonin and norepinephrine reuptake and has a weak inhibitor of dopamine reuptake. The main things to remember with SNRI is that if you're starting them and they're on for at least a few weeks or a few months, you need to taper these medications to avoid withdrawal symptoms. And it's helpful to use in concurrent management of depressive symptoms. The first one we will talk about is duloxetine or Cymbalta. A note for duloxetine, you want to avoid if someone has a creatinine clearance of less than 30 or if they have end-stage liver disease. The most common side effects of duloxetine are nausea, dizziness, headache. The approval of using for the FDA for duloxetine is fibromyalgia, anxiety, depression, chronic MSK pain, and diabetic neuropathic pain. Off-label use can be for chemotherapy-induced peripheral neuropathy. You need to give it about 4 weeks to start taking effect. The other SNRI that's commonly used is venlafaxine or Effexor. Again, you need to reduce the dose if someone has a reduced creatinine clearance. You want to avoid in someone with cardiac disease. And like duloxetine, you want to taper because you can have withdrawal side effects, which can be problematic if you have a patient that can no longer take PO and all of a sudden is in the hospital. You do need to monitor for those withdrawal side effects. For side effects for venlafaxine, it's weight loss, nausea. This one can cause increase in blood pressure. So if someone has uncontrolled hypertension, it's a medication you would want to avoid. And it can initially cause anxiety. It's FDA approved for anxiety, depression, panic disorder, social anxiety disorder, and off-label use for migraines, diabetic neuropathic pain, OCD, and PTSD. And the duration similar to duloxetine, it might be a little bit longer to take full effect. So there's been some studies looking at gabapentinoids versus duloxetine specifically for neuropathic pain, and they've shown that it's nearly equivalent for the neuropathic pain. Both of them can have withdrawal effects and should be tapered, and both can also be used for general anxiety disorder. For gabapentinoids, you might have less drug-drug interaction. It may help with sleep a little bit better, and it may be preferred in those with liver failure, or can be used at lower doses if you have a reduced GFR or kidney impairment. For duloxetine, it's easier to titrate to therapeutic dose, and that's true more specifically compared to gabapentin. It may be better for chemotherapy-induced peripheral neuropathy. It may be better for depression, and it's better for osteoarthritis. So these are kind of some considerations to look at when you're comparing the two and trying to think about which agent to use as a neuropathic agent. The next category we will talk about is TCAs. They inhibit serotonin and norepinephrine in the CNS and increases the descending pain inhibition. It's primarily used to treat depression, but it can have off-label use for chronic neuropathic pain. All TCAs can be sedating. For our geriatric patients, the TCAs are commonly on the Beers criteria, so it doesn't mean you should never use them in our older adults, but it's something to be cautious about. The big kind of black box warning is there's suicidality risk, and you want to avoid in heart disease. And if you have a patient that's above the age of 40, you want to get a baseline EKG. You can take it for 6 to 12 weeks to see the full effect. Some people may get a benefit in sleep already at 1 week. All of the TCAs have a lot of drug-to-drug interactions, so it's really important to monitor for polypharmacy and to make sure that you're not getting increased side effects or consequences from being on the TCA. The two main ones we think about commonly are nortriptyline, which has less anticholinergic effects. So it may be a better option out of the two for older adults, and it's less sedating. Amitriptyline, on the other side, is very sedating. So if someone is really struggling with insomnia, it may be a better medication for them. And with amitriptyline, you want to watch out for orthostasis. In terms of topical agents, the indications for topical agents are post-herpetic neuropathy or mixed peripheral focal neuropathy. The main topical agents we think about are lidocaine and capsaicin. Lidocaine can be received over the counter, or at higher doses you can get a prescription for it. It works at the sodium channel blocking. It decreases ectopic filing of peripheral nerves. And it may take 2 to 3 weeks to take full effect, though some patients may get impatient and not wait that full time. Capsaicin is another topical agent that you could use. The mechanism of action is a selective agonist of the TRPV1 channel. You want to monitor for any redness, rash, or burning. You want to specifically counsel patients to be careful not to have capsaicin near their face or eyes and to wash their hands thoroughly after using it. And then when we think about other topical agents, there are definitely other ones out there. There's diclofenac, there's ketamine, there's baclofen. There's limited evidence for neuropathic pain. Diclofenac, we think more commonly is used for musculoskeletal pain. And there may be anecdotal evidence for ketamine and baclofen, though it's really case specific and it's not as commonly used as topical agents. In addition to the medications that we've already talked about, we just want to talk about opioids as a combination therapy. We want to talk briefly about methadone, briefly about cannabis, and just say that there are a variety of interventional therapies, including epidural injections, sympathetic blockages, radiofrequency, Botox, neurostimulation. We're not going to go into detail about these interventional therapies, but we wanted to name them just so that you are aware that these options exist. There's mixed data for support, often limited in these interventions for inpatient and outpatient, but it's definitely something to consider for patients. So what do we mean when we say combination of medications? We specifically mean that the patient is on an opioid plus another medication. So opioids are not recommended on its own or first line for chronic nociceptive or neuropathic pain. So the whole idea with combination therapy is two distinct classes of drugs that can be used in combination with non-overlapping side effect profiles and hopefully with minimal potential adverse interactions. So 50% of patients that have neuropathic pain are on two different drug categories, and combining low-dose adjuvants with low-dose opioids may be as effective as using one medication at a higher dose. Adding a second adjuvant to an opioid has marginal benefit and high risk for adverse effects or drug interactions. So you want to think about kind of what is the first medication to start and what would augment the pain relief, but you don't want to kind of stack up many of the medications because at that point the side effects may cause may be more harmful than beneficial. Recently, this past year, there was a talk at AHPM, the American Academy of Hospice and Palliative Medicine conference, that looked at these combination medication therapies and had a nice summary table looking at different medication combinations and looking at specifically, you can see at the table, whether it's post-surgical, whether it's peripheral neuropathy, just neuropathic pain or spinal cord injury. And it showed that with combination, generally there was a greater relief of pain relief, and in some cases improved mood, quality of life, and that these combinations produce more analgesia than the monotherapy. So it's something to consider for combinations when you're using opioids plus a different medication. We wanted to briefly talk about methadone. The mechanism of action for methadone is NMDA, and it also works at the serotonin reuptake inhibitor. The main evidence for methadone is in chronic pain. There's mixed evidence for neuropathic pain. Oftentimes, this is not going to be your first line. And I'll just mention that sometimes, especially for our geriatric patients, a very low dose of methadone, such as 2.5 even once a day, can really help with pain, and is still worth trying if someone has a lot of chronic pain and some of the other agents aren't working or the risk profile is too high. This summary below is specifically, I think, we know with chronic pain, methadone can be helpful, but the evidence is mixed with neuropathic pain. So I just wanted to show that, again, there's mixed data when it comes to neuropathic pain, and you can see the various studies that it did help, and in some studies that it was unknown or didn't help. I'm going to pass it on to David to talk about cannabis.
So cannabis is something that a lot of patients, are aware of or might be using, or might have questions or curiosities about. So it's always important, just as a reminder, to ask patients, if they are using cannabis or other forms of drugs, just so you can be aware as part of their healthcare team. And so we know that for cannabinoids, they interact with the cannabinoid receptors, and these can modulate pain perception, things like inflammation, and it can help with analgesia, but also antiemetics and appetite stimulation. There's a lot of different drug-drug interactions, and they can actually reduce some of the cancer treatment responses. And so it's really important that when you're working with oncology patients, that you're encouraging them to make sure that they're talking with their oncologist about this, because a lot of the different regimens, might have specific interactions that we want to be aware of. There are two forms of synthetic cannabinoids. There's dronabinol and nabilone, which are both approved for nausea associated with chemotherapy, and then dronabinol specifically for anorexia associated with HIV or AIDS weight loss. It's just important to note too that some of the MASS guidelines that came out in 2023 showed that overall this was cannabis was ineffective for treating cancer pain, and so that they were not recommending using cannabis as an adjuvant analgesic, because there is potential risk of harm, specifically for patients that are on checkpoint inhibitors. This isn't saying that you cannot use it, but typically we'd recommend close collaboration with the oncology team, not using this as the as an adjuvant analgesic, and if you're using it, considering it for use for other things like nausea or appetite stimulation. There's also a lot of really great non-pharmacologic treatments that we encourage, considering for patients, not just with nociceptive pain, but also with neuropathic pain or pain that needs a multimodal approach. Physical therapy is something that has obviously numerous benefits. We always talk about movement being medicine, which is something that is not just good for their physical function, but it can improve our mood too as well. This is something that we should be, thinking about for all patients, even if they have a serious illness, even if they are a geriatric patient. We can all try to maximize patients' physical therapy abilities. There has been evidence showing that doing aerobic exercise or resistance exercises can have improvements on pain perception and help alleviate neuropathic pain intensity specifically.
So we wanted to talk about a few other non-pharmacological treatments. One is scrambler treatment. Some of you may have heard about it, some may not have. If you haven't heard about it, it administers electrical stimulation through the skin via electrodes placed above and below where the chronic pain is felt. The aim is to really capture the nerve ending, replacing the signals from from where you're experiencing the pain to trying to not experience pain. So it may be helpful for those with chemotherapy-induced peripheral neuropathy. There's not enough data out there to recommend it one way or not for cancer patients, but it's something to be aware of because patients may ask you about it. The other treatment to be aware of is called TENS, or transcutaneous electrical nerve stimulation, which actually some physical therapists will do, or you might see PM&R doctors doing it, but it delivers low intensity electrical signals through pads on a skin at different pain sites. It's more affordable than it used to be, and you don't necessarily need medical supervision for it. In terms of evidence, it's kind of inconclusive. Some patients may find it helpful, some may not. It's worth kind of A, being aware of because patients may ask about it, and B, there's not really a high side effect profile. So if patients want to try it, I don't think there's any reason for them not to try it.
There's also, in addition to non-pharmacological physical treatments like we talked about, there's also other complementary therapies like music. Music therapy can really engage the brain's limbic system. It can reduce stress, anxiety. It can also promote relaxation, help improve patients' emotions. It also can actually have physical effects on the body, like lowering heart rates, helping with blood pressure. These are a couple of studies that have shown that, for patients with neuropathic pain, that it has, significantly decreased both their pain and anxiety levels. And so if this is something that, your facility is able to offer, it's definitely something that we'd want to consider for patients. There's also things like massage therapy and reflexology and acupressure. There's mixed evidence for this, specifically for neuropathic pain, but it also might be helpful for patients with other symptoms. If it's helping them relax, or it can also contribute to their well-being. But it's not something that there's, specific great evidence for neuropathic pain specifically. For acupuncture, there's also insufficient evidence to recommend its use for neuropathic pain. But just like massage therapy, there might be other benefits to the patient, relaxation, things like that don't rule it out, but not specifically for neuropathic pain.
Okay, so we have talked through a lot and a lot of different types of medications to approach as adjuvants, and we wanted to just kind of wrap it up and put it all together. So kind of going to the beginning of our talk, just stressing the importance of getting a thorough pain history and exam to really better understand the cause of the pain and to be able to differentiate the types of pain so you know better how to treat it. Oftentimes we kind of skip through that detailed history and kind of make assumptions on what we should treat. And so really going back to the good history to figure out what is going on with a patient can really help you think about the mechanism of action of a treatment that would be most helpful. So choosing a treatment, you want to base it on the cause of the pain, the patient's age, comorbidities, renal and liver function, and really looking at what some of the other medications they're on and how they can interact. It's important to provide education and manage expectations. Oftentimes, pain is subjective, and unfortunately, some patients come in thinking we could take away their pain completely. That's often not the case with serious illness or chronic illnesses. So it's important to manage expectations and ask, what would be a tolerable level of pain, or how can we help reduce your symptoms to a less degree so that you can be able to play with your grandchildren, be able to go for a walk, be able to watch TV without any discomfort. And it's important when you're managing expectations to also talk about the duration of symptoms. Some of these pain symptoms may not go away for a while, especially with chemotherapy-induced peripheral neuropathy. You may expect some improvement initially, but if it's been going on for a year or two, chances are it's not going to get better. So again, managing those expectations can be really helpful. And remember, with a lot of these, there's limited evidence for many pain treatments, and that combination therapies may be preferred, especially with opioids or low dose opioids and an adjuvant. So just keep in mind, not doing too much polypharmacy, but keeping in mind that you may need a combination of medications to really help someone's nociceptive or neuropathic pain. And on that note, we're going to transition to a board review question. So this is a case of a 48-year-old man with advanced HIV that comes to your palliative care clinic for the evaluation and treatment of chronic pain. He has severe HIV neuropathy as well as chronic lower back pain. He also has chronic renal insufficiency from diabetes with a baseline creatinine or kidney function of 2.5. Trials of non-opioid pain medications and adjuvants for neuropathic pain have been unsuccessful. Today, he tells you that unfortunately he's resumed using heroin to control his pain. Which of the following opioid analgesics is safest and most likely to be effective for this patient? A, hydromorphone or Dilaudid. B, oxycodone. C, extended release morphine, also known as MS-Contin. D, acetaminophen with codeine. Or E, methadone. I want you to take a minute to pause either your video or just to think about what your answer would be. And we'll go on to share the answer, but make sure that you pause and think through this yourself. So the answer to this question is E, or methadone. And the reason for methadone in this particular case, it has a lower risk of abuse and a much lower risk of excitatory effects in a patient with renal failure or someone that has an elevated creatinine. It's primarily excreted in the stool and therefore does not depend upon the kidneys for clearance of the metabolites. Treatment with long-acting agents for chronic pain in patients diagnosed with substance use disorder is likely the safest and most effective. These medications provide less reinforcement of the addictive behavior and less early withdrawal or end dose failure. Methadone maintenance prescriptions for the treatment of opioid addiction, as opposed to prescriptions of pain management, can only be given in approved methadone maintenance clinics. However, any physician with a valid DEA license may prescribe methadone for pain, even if a patient has a coexisting substance use disorder. Compared to the other choices that were listed, methadone is cheaper, it's longer acting, and it may have higher efficacy in patients with neuropathic pain, as discussed earlier in our talk. And that's because there's a common component due to the NMDA receptor antagonists. In terms of the other options, all hydromorphone, oxycodone, and morphine should all be used in caution with renal failure, as the metabolites may accumulate and produce neurotoxic effects such as delirium or myoclonus. Morphine is the one we commonly think of as absolutely avoid if someone has renal impairment, but you should be aware that oxycodone and hydromorphone should either be spaced out more or be used with caution or start with lower doses, as someone with renal impairment and still may build up given how it is excreted. The other thing is with acetaminophen with codeine. Codeine has extremely weak analgesic ability, and it's ineffective in a significant proportion of patients who lack the ability to metabolize it. Also with acetaminophen, like David had talked about earlier, the concern is that combination medication. So you may be taking too much acetaminophen, which can be hepatotoxic and nephrotoxic. So if we're trying to do analgesia for a patient, I would recommend splitting up acetaminophen or Tylenol with an opioid or a different medication, just so you can titrate how much Tylenol you're getting and how much of the other medication, and not having to combine the two. So in this particular case, given that you've tried some adjuvants that haven't worked for this patient, it's reasonable to escalate to an opioid medication. And in this patient's case, given his chronicity of his pain, it makes sense to try methadone, given that we know his pain's going to be ongoing. It's a safer option that's longer acting, and it can be given by any provider, again, with a DEA license. It doesn't have to be at a set clinic. We wanted to share with you our references, which is a long list, but also just thank you for being sitting through our talk and learning about adjuvants for neuropathic and nociceptive pain and the alternative treatments that can be given as well. So thank you for your time, and we hope you enjoyed this session.